Good morning, everyone. Can you hear me okay? Can you hear me okay? I would thank you for joining in, but we're going to get started with our first speaker. So I have the pleasure to introduce you Professor Gould, who directs a unit within the Division of Child and Adolescent Psychiatry focused on suicide research. Gould has received continuous federal funding for her research on suicide prevention for more than 30 years. She is recognized globally for her outstanding contributions to suicide prevention, including telephone crisis services, chat crisis services, continuity of care, enhancements in the ED and youth suicide screening programs. Most recently, she led the successful effort to establish a national youth-safe suicide hotline, launched in 2021. Professor Gould is a significant contributor to the Diana Wellbeing Study and mentor to so many persons in suicide prevention. So without further ado, we'll hear from Professor Gould.
Thank you very much, and I'm delighted to be participating in the conference. I'm sorry I can't be there in person. Maybe next year. That'd be great. So I'm going to share. Let me just get the slides. Oh, it says the host has disabled the participant screen sharing. So I just need someone to allow me to share my screens, share my slides.
You should be able to share now.
Okay, let's see. Yes, that's good. Okay. Okay, and so what I will be talking about is the establishment of the new 3-digit dialing code for the National Suicide Prevention Lifeline in the US, and that dialing code is 988. Okay. And national crisis lines in the US were first highlighted in the 2012 US National Strategy for Suicide Prevention. And they've continued their prominent position, to date. Yet in 2001, when the first national strategy was published, suicide lines were noticeably absent. And at the time of the 2001 national strategy, the evidence base for crisis lines effectiveness was considered insufficient to include them in the strategy. So the major milestone in 2001, and it was the advance of crisis lines in the US by funding a national network of local certified call centers by in our federal government. The agency that funds it is the Substance Abuse and Mental Health Service Administration. And in this next slide, that I wanted to share this with you is to show that the development of this 3-digit dialing number for crisis services took many years in development. And the 988 builds upon the existing National Suicide Prevention Lifeline, which has been in operation since 2005. So as I mentioned, in 2001, our Congress appropriated funding for a network of suicide prevention crisis centers. 2005, the National Suicide Prevention Lifeline was launched with a 10-digit number that was probably not all that easy to remember in times of crisis. In 2007, when I said Substance Abuse and Mental Health Services Administration, I'm just going to shorten that to SAMHSA, that SAMHSA and the Veterans Administration partnered so that the 10-digit number was an access point for our general population, but also for veterans and military so that they could call the Veterans Crisis Line. That was a major advance because at the time, the VCL was thinking of using a separate number, so that I remember those discussions where they decided to partner with the Lifeline. And 2013, chat services started. 2015, a disaster distress helpline was started, and so on. But it wasn't until 2020 that our federal Communications designated 988 as the 3-digit number, it said that that would be okay. It wasn't funded yet, but at least it started the implementation development. In 2020, Lifeline first began incorporating texting services and so on. And it was in 2022 that the transition to 988 was complete. So it was just this past July, this past summer. And I'll be going into more detail about what the Lifeline is and what 988 is. But for now, I'll say the Lifeline is a national network. It's not just one crisis center. It's a national network of over 200 local independent crisis centers that are equipped to help people in mental health related distress or experiencing a suicidal crisis. And this help can be provided via call, chat, or text. It's available 24 hours a day, 7 days a week across the US. It provides free, confidential support to people in crisis. And I'll now briefly present the empirical evidence on the effectiveness of crisis lines in the US that emerged after the 2001 national strategy. The evaluation of the national network of crisis lines, as I had said, has been ongoing since the network's inception in 2001. And what's really been unique about the relationship between our evaluations and SAMHSA and the Lifeline is that the results from the evaluations have been used by SAMHSA and Lifeline almost immediately to shape best practice standards across the network. So new practices that emerged because of our evaluation findings in turn led to additional evaluation studies and so on. And so we've described this as an iterative process, which has been described as being unique, and it's considered to be a gold standard in data-driven decision-making. So as Guyana starts to think about planning crisis hotline services, the thing to consider is to also fund some evaluation efforts as well, because it's the only way that you'll know what's working and what's not working. And over the course of our nearly 20 years, we have collaborated with nearly a third of the network. So about a third of all centers in the Lifeline network, about 75 centers, have participated in various evaluations all across the US. And our assessment methods have included interviews with callers, providing questionnaires to callers and, we've called chatters, questionnaires that the crisis counselors have completed. We've monitored calls in real time. We've coded call recordings. We're currently coding the call recordings to get some objective measures of what the counselors are doing and how the callers are, their behavior and crises are changing. We've coded chat transcripts. We've also evaluated the crisis text line in the United States so that we've had questionnaires with texters as well. And I'm not going to go into details of the studies. In last year's conference, I did go into a lot more detail, but I do want to summarize the findings before I describe the 988 and the Lifeline's procedures in more detail. And there are 2 slides that are in the presentation that lists all our peer-reviewed publications. But in summary, over the course of 20 years worth of evaluation research, we've demonstrated that individuals at risk of suicide do utilize suicide hotlines. When we started our work, there was a myth that suicidal people didn't utilize hotlines and that it was, other people who were in distress, but not really at serious risk of suicide. And we dispelled that myth, that we saw that, that over half of our callers had previous suicidal behavior, and I'd say about a quarter of callers to the hotline are in, have serious suicidal, current suicidal ideation. What we also found is that callers experience reductions in their crisis and suicidal states over the course of the crisis call, that with regard to callers at imminent risk of suicide and those that were deemed to be at risk of engaging in suicidal behavior right then and there, if the counselors didn't do something to de-escalate their risk. And it turned out that we found that crisis counselors can collaborate with callers to de-escalate imminent suicide risk without the use of 911, which in the US is our emergency number, or going to an emergency department. Sometimes the crisis callers did have, the crisis counselors, did have to call 911. So I don't want to give the impression that that's never done, but that we saw that in a large proportion of imminent risk situations, they were able to de-escalate the situation. And, less than half required any emergency, services being sent. But what we also found is that callers may experience continued or recurring suicidal thoughts in the weeks following their crisis call, which indicates a need for continuity of care after the initial crisis call. And so SAMHSA started funding what is a follow-up initiative whereby the crisis centers, the crisis counselors could call the individuals at risk for suicide back after their initial crisis call. And we've evaluated that as well. And follow-up calls are an important suicide prevention tool. So again, as Guyana is developing these crisis services, a thing to consider that in addition to implementing the capability for people to reach out to the crisis centers via, let's say, telephone, chat or text, it's very important to fund the capability for crisis counselors to be able to follow up with callers and chatters and texters to see if they're still safe, and to try to help them connect with, longer term, mental health help. What we also saw was that crisis chat services, and I could say text services, are utilized by a younger and actually higher risk population, and that they're very important adjuncts to telephone hotlines. So, establishing a telephone hotline, critically important, but to really increase access, particularly to younger people, it's very important to implement chat and especially text services. And we've seen that Lifeline centers have been shown to be more effective than centers outside of the Lifeline network, probably due to more training, standardization of training, and more oversight. And so these two slides, will provide the list of articles that we published. They're all open access, so they're readily accessible online. And to give you many details about the methods that we used. And I'm always happy to share the assessments that we've developed, or to at least provide some guidance on how to adapt them. So now 988 Suicide and Crisis Lifeline is our national network of crisis services. And so what was previously called the National Suicide Prevention Lifeline, you could see with a 1-800-273-8255, which would be quite challenging in times of distress to remember that. This network can now be reached by calling, texting, and chatting with the 988. And having 988 be the three-digit crisis number has propelled crisis centers in the US into the epicenter of plans for an improved mental health and suicide crisis response system. So how the Lifeline or 988 Lifeline works overall is when someone calls, they're given a choice to connect directly to the Veterans Crisis Line or to connect to the Lifeline Spanish subnetwork. And you can see the majority of contacts are calls, but texting and chatting options are growing in demand. This was fiscal year 21, and these numbers have already increased dramatically in fiscal year 22. And chat and text are currently only available in English. And we anticipate that 988 will continue to grow and evolve in the coming months and years. And there's been quite an increase in federal investments in the network. In fact, 18-fold increase from, well, a few years back it was only 7 million, then it went to 24 million, and now it's over 400 million. So it definitely is a national priority. The thing to consider is that in the past, this network has been massively underfunded and under-resourced. And, it was a patchwork of local, state, and private funding for the network. And so it really was not meeting the needs. And even still, it's somewhat of a patchwork. And so the only way to transform a crisis care system in the US or Guyana is that it really requires a commitment, making it a priority, and then providing the funding for it. It can't be done without that commitment. And that it really has to be recognized that this is a very exciting time in the US, hopefully an exciting time in Guyana. Otherwise you wouldn't be having the conferences that you're having and the work that you're having, with the commitment to prevent suicide. But whereas 988 may be at the core of a transformed crisis care system, it's not going to be built overnight. And as I really want to emphasize, it's going to require the collaboration, commitment, and support by both public and private sectors to make it, effective and sustainable. And in the short term, this funding is going to be used to strengthen and expand the current Lifeline Crisis Center infrastructure and increase the capacity to make sure that trained crisis counselors are available to quickly respond to 988, again, via call, text, or chat. But in the longer term, the vision is to build a robust crisis care system across the country, hopefully one day across Guyana, that links callers to community-based providers who can deliver a full range of crisis care services if needed. And I'll be describing this in just a moment. And so what I mean is, mobile crisis teams or stabilization centers. And so it's going to require more than, responses to crisis calls. And sort of the motto of this expanded crisis care system is that we're envisioning a day when everyone across the US and hopefully in Guyana will have someone to call, someone to respond, and a safe place to go for crisis care. So the motto has been, someone to call or text, or chat with, someone who's going to respond, and a safe place to go for crisis care. So again, it's 988 and crisis centers are at the hub of an integrated crisis care system. And I mentioned that also involves universal access to mobile crisis teams and crisis stabilization facilities. And so according to this model, crisis call centers would be responsible not only for fielding calls or texts or chats, which they currently do. They currently de-escalate crises and refer callers to additional services as needed, but that they would also be used for tracking and coordinating individuals' use of these other services in a role that has been described as a, quote, care traffic control, in the same way that we have air traffic control, that no one, the ball won't be dropped or the baton won't be dropped, that once someone calls, they won't fall through the cracks of a, of a safety net. That someone, some team, will be responsible to make sure that they stay safe and get the services that they need, even after the call. So I have a slide to show you what I mean by this model, and that these data are from one of our states, this Arizona. This was fiscal year 2019. This was even before 9/88, and to show how many calls are resolved by without dispatching emergency services, and that you can see that from this data, about 80% were resolved on the phone. Someone calls, the crisis can be resolved. You don't have to call ambulance or law enforcement, emergency services. But for those cases that are not resolved, mobile crisis teams have been called. And you can see that another than 70% of those that hadn't been resolved by the phone get resolved. And that this is, face-to-face encounters that have been sent out by folks who have mental health training. And this then can resolve crises without the need for transport to a higher level of care. Then for those individuals where their crisis wasn't resolved on the crisis line, wasn't resolved via mobile crisis teams, crisis facilities in the community are able to then resolve other, keep the people safe without, again, resorting to higher levels of care, such as hospital, ED, or jail. And that continued stabilization is the percentage of individuals with a mobile crisis team or crisis facility encounter who did not have a subsequent ED visit or hospitalization within 45 days of that initial call. So as you can see on this slide, a very high percentage of calls were resolved by the crisis line and at subsequent care resources without the involvement of jails, EDs, and inpatient admissions. But this is not a trivial crisis care system to build, as you can imagine, and it requires a lot of communication between crisis lines and mobile crisis and crisis care facilities and wraparound, post-crisis wraparound services in the community. So as you all are thinking about developing a crisis care system, clearly what you do on the crisis line is just critically important. But it must be remembered that you need to be thinking post-crisis line, services as well. And that's, at least in the US, and I would anticipate in Guyana too, the overall goals are to divert individuals in mental health crises away from jails and emergency departments, to reduce unnecessary psychiatric hospitalizations, and again, to reduce law enforcement generally, their involvement in mental health crises that need folks who are trained to deal with these crises. Of course, law enforcement can be trained to have these skills or work in collaboration with people in, who are mental health professionals. And those are models that are effective as well. But you need that mental health, someone with some, expertise in working with people with mental health crises to make them safe in the, in the intervention more appropriate. So I want to give you some information about, well, what's happened after 988 was implemented, and now it's ongoing. Because many of us were concerned that would the system be overwhelmed, on day one, and that these calls and texts and chats wouldn't be answered in a, at all, or in an appropriate time. And because of the increase in access. And even in this week or so, right after the 988 was rolled out, that there was a 45% increase in the number of calls and texts and chats combined, and a much more, much greater jump in actually texts and chats. And if you compare, this was just comparing the numbers from the week before to the week after 988 was implemented. If you look and compare the numbers from the same time last year to that same week, in 2021 to that same week in 2022, there was a 66% increase. So when you do have a 3-digit number, the more people are going to call because it's more accessible. What's been very commendable by SAMHSA is that they are providing performance metrics online, public access on an ongoing basis. So they had it for August, now they have it for September soon. It should be available, for October. And so I'll explain, what these terms mean as well. And so when someone calls or chats or texts, when that is initiated with the 988 Lifeline, that's a contact. And by routed, that means that these contacts are routed to a center after the person listens to a greeting, if it's a call, or sent to a counselor after answering a pre-chat or pre-text survey, very short survey. Now, not all of those calls are answered. You can see it's a very high percentage, but the system is working to even make that higher. And sometimes people will, will hang up. But answered means the contacts that are connected to a center and then engaged by a counselor. So sometimes someone will call and then hang up before they're even talking to a counselor. But you could see, especially with text and chats now, it's extremely high with regard to the answer rate. And calls, when we see a number like this, which is high, but the work is in progress to make it even higher. Now, by abandoned means that contacts that disconnect prior to being engaged by a counselor. So disconnections may happen for a number of reasons, including but not limited to the person seeking contact changes their mind about seeking care at that moment. The person no longer feels they have maybe privacy or safety in their environment. There may be a random technical service interruption, which may occur due to internet instability or carrier glitches, and so on. But that the average speed to answer is the next metric, and it is, and I guess I should say the abandonment rate is relatively low, but hopefully it will get to be lower. The average speed of answer is the average time a contact takes to be answered after listening again to the call, greeting, or answering the pre-chat or pre-text survey. And this is an average, and so there's a range as well, at different centers in different states at different times of day. But overall, you can see that it takes a, again, relatively short period of time, on average, 42 seconds to, to answer the call, chat, or text. But again, the goal is to even make it shorter. And then the average contact time is the amount of time that the counsel spent talking or chatting or texting, with the person. Again, it's, an average. It takes longer to engage someone via text. I've been trained as a crisis text counselor, and I've been quite amazed at that you can resolve a crisis via text. It was something that I actually was very dubious about before, when text was being developed. But it does take a little longer with regard to time to develop that engagement with a texter and to develop collaborative, problem solving with them and to resolve that crisis, compared to calls. And what I've been actually shocked by when I've listened to calls, that 12 minutes or 13 minutes seems so short, right? When you look at just the number. And again, they can range from actually 5 minutes to, 2 hours. But what I was very surprised, actually pleasantly surprised, is that you can resolve a crisis in 10 minutes. Not for everyone, clearly sometimes it takes 45 minutes. But when you see this number and you think, well, how is that possible? Someone is talking with someone for 12 minutes. But, I've heard it, and, we'll be documenting it more systematically than my just saying that I've heard it and, anecdotally. But these services can be very powerful because of the training that the crisis counselors receive. But there's still there's still areas to improve, and that, key challenges that we identified by our evaluations, because there's still room for improvement in communication between the crisis centers, 911, EDs, and other crisis and emergency services. Mobile crisis teams and stabilization facilities are not universally available. They're certainly, that's the goal, and they are available for many Lifeline crisis centers, but not all, and the goal is to have them available for all. And SAMHSA, has a priority to establish and evaluate mobile crisis teams as well. And with regard to, I put this on both because I do evaluation research, but it's also that as you all are motivated to develop a system that a crisis care system, that there are certain evaluation metrics to keep in mind to see how things are working. And so at a systems level, certain questions to be answered are, how often are 911, that's the number that we have, as I mentioned, pre-988, that was for all emergencies, whether you're having a heart attack or, you're being accosted. But how often are 911 or police called by Lifeline crisis centers? How often are mobile crisis teams and stabilization units used? To what extent is information shared between these services? And does disposition vary for different ethnic and racial and gender groups? Because, we want these services to be fair and equitable and be able to reach, everyone in our diverse population. With regard to at an individual level of research or evaluation, to assess the fidelity to which counselors are following the trainings that they get, and to what extent is there burden and burnout among the crisis counselors. It's a hard job, and that again, as you develop the system in Guyana, these supports have to be put in place for the crisis counselors as well, and chances to debrief and to be supervised and so on, so that the burden and burnout, are minimized. And then with regard to the callers and texters and chatters, again, at an individual level of research, how were the imminent risk calls or chats or texts resolved? And as I was mentioning in terms of equity, to what extent is 988 being used by different ethnic, racial, gender groups? And, does the effectiveness vary for these different groups? And we've conducted many evaluations on short-term outcomes, which is why I haven't put them on this slide, but not longer-term outcomes. What's the post-crisis recovery? What are the profile of individuals who use 988 on a repeat basis? Are callers, texters, chatters connected to mental health services? And to what extent did, these folks in crisis attempt suicide or die by suicide, in the months or years after their crisis calls? These are things that are currently not known. And with regard to mechanisms, what are are there different types of crisis interventions that provide a better fit for individuals with different presenting problems? And what's the relationship between counsel behaviors and interventions with these outcomes? What we have seen from our studies is that it's the counselor's engagement with the caller or chatter or texter, because we found it across all these media. It's the engagement that is key to the effectiveness of the intervention. You can't do this robotically. You can't be a crisis counselor and just give a series of questions or a script. You really have to be trained to validate the individual, acknowledge their pain, be able to sit with them, not in real space, but you know what I mean, to really be able to be active in that listening process, to make the person in crisis feel valued. Then they'll start to be able to share what's been going in their on in their lives, and be able to talk about their suicidal thoughts and intent, and then be able to work collaboratively with you to figure out how to stay safe and work out the problems. So these, we know that with regard to mechanisms, it's this engagement, but there may be other interventions that are a better fit for different, people. And then even though I have not been, this is artificial language processing and, the examination of linguistic features is not my area of expertise. I have been collaborating with some, folks a bit, but, there is room for, and people are excited about this area of research as well. And so I'm going to end with this slide because what SAMHSA has also done is that they have provided a lot of online resources that you might want to examine by going to this website. As you can see, www.samhsa.gov /988, and explore the really on so many online resources, including slides, and I've had some of these slides in, I had them augment my presentation as well. And so I will end the sharing of my screen at this point, stop share, so that, and hopefully the timing has worked out okay. And this has provided enough information to at least whet your appetites and to find out more about this crisis care system. So thank you.
Thank you, Dr. Gould. That was a really informative presentation, and we learned a lot about the beginnings and the middle part, and of course the conclusion to this wonderful resource in 988. There was a lot of substance in that presentation. So we do have, the timing is perfect. We have good enough time for questions and then a good enough time for transitioning to the next speaker. So we have an audience here. I will take in-person questions first, and then I will move to the chat. Are there any questions for our speaker?
I'm getting late, but I actually saw something there. They talk about
Wait, hold on. Can you hear the question?
You know, I can, so I'm going to have to ask you to repeat it. After they ask the question, if you would repeat it, that would be good.
Okay, we
Thank
will.
you, sorry.
Odessa. What is your question now?
Okay, I saw that spoke about the counselors at Cornell. So my question is, what measures do you have in place for those counselors who are overloaded with work and they may be stressed, going to depression and all that? What measures do you have in place to support things like that? Because I mean, we're humans too, and the work might be so much at times, you know, sometimes you don't know who to turn to.
Yeah.
So I just want to know if they have like trainings for them or they have persons that they will refer them to in that case.
Yeah, Dr. Gould, the question is what measures and things, what kind of interventions or follow-ups are given to the crisis line responders who might be experiencing burnout? You had mentioned burnout in your talk, and she just wants to have a better idea of what, how you're addressing that or how that's being addressed, I guess on a large scale, understanding that they have a hard job and these crisis persons might be experiencing burnout.
Yeah, now that hasn't been the focus of our evaluations. So we have, when we've given counselors questionnaires, it's really about the callers. But I know from working with the Lifeline and being on their standards training and practices committee for all these years and talking with so many crisis centers, that this is something that is addressed from day one of the training, that the needs of the crisis counselors are also at the forefront because they can't do their job if, you know, they themselves are, you know, in such stress. And it is a very stressful job. You know, you're dealing with lots of suicidal people. And so there are, you know, the supervisors are always there for the crisis counselors as well. So that in real time, if a call or chat or text is that the counselor feels overwhelmed, that they don't know how to deal with the particular situation, they can call on support or a supervisor to guide them so that they never felt as if they're on their own to deal with this, you know, the person in distress. So that could avoid some burnout, right? Because if you think you're by yourself and that there's no one to fall back on, that could be overwhelming. And then there are weekly meetings. You know, it could be that same day as well, that if someone has had a particularly difficult call, I'll say call just to, so I don't have to call text chat. If there's a particularly difficult call, that there will be, they can debrief. So again, that support system is built in and has to be built into any new system. And then pre-COVID, people were at the same call center. You know, they would show up, they would have their shift. And so there would be other people around that they then could talk so that their level of connectedness, you know, was high. During COVID, all of a sudden the model had to shift and really shift overnight, where people had the capacity to then work at home because they had to be isolated from the other crisis counselors. So that was a little more challenging, how to provide them with that support. So having crisis counselors, it's good to have the flexibility of being able to be on site in a call center, but it's also good to have the flexibility to be able to work at home, especially if you're doing an overnight shift. But the support systems for the crisis counselor have always been considered to be key. So it's not as if there's a particular measure that there are measures of burnout, and that could be something that a crisis center may want to, you know, initiate quarterly or so on. But I haven't heard that. I have, you know, I've heard it in other settings, but I haven't heard that being used where there may be a questionnaire that they ask their crisis counselors to complete, and then, see what's going on. But they do ask them about it. The supervisors ask the counselors about it. But there are measures of burnout, clearly depression, if, people are interested in, in obtaining them.
Thank you so much, Dr. Gould, for that. And I think it's really pertinent to what's going on here in Guyana as well, that they're not alone. They're not alone. They're responding to these telephone, but they're not alone, whether physically with COVID or having support staff there.
Right.
Yeah, that's really, we have another question in the audience.
Good morning. I came in a bit late, but I was able to capture some of what you were teaching us. My questions have to do with whether or not you've looked at the non-medicinal techniques of art as in colors, music, and play as a methodology to alleviating or helping depression or persons who are prone to suicidal ideation, not medication, but the non-medicinal techniques. Have you looked at art teaching, the fact that colors matter, play-based healing, and as well as music, and whether or not in some areas of your study, I've been asking this question since yesterday, the amygdala is that part of the brain that is responsible, I think, for some of our most rational thought. Whether or not some of the things we are seeing post-pandemic, or we're still in the pandemic, but because of the stress we've been under for the past 2 years, whether or not we've been experiencing, some persons are experiencing an amygdala hijack. I thank you.
I think I'll let you elaborate, but I think I caught it. I think I caught the question. So I'll start to answer, but if you see that I'm answering a different question, will you stop me and then say that wasn't the question? So when you talk about that amygdala hijack thing, the crisis, that's, when someone's in crisis, all of a sudden they're, right, the prefrontal cortex can shut down, right? They're totally overwhelmed. And they're thinking that suicide is the only option. And the crisis counselors first have to get the crisis, I'll say, caller in a space where all of a sudden these processes are not hijacked, right? That they can then start collaboratively problem solving. And that the crisis counselors do engage with the person at risk to find out what coping strategies they've used in the past that have helped them, resolve their distress. Some of which, and this is where I think I caught the question, some of which may involve the person painting or listening to music, or, other ways to soothe that distress. So that, and then they say, well, when you get off the call, what do you think will work to keep you safe? And that some of that, quote, action plan, or safety plan, Barbara Stanley, who's here at Columbia, and Greg Brown, who's at another university, have developed, and I think many people may be aware of, safety planning intervention. And in terms of if someone starts to feel like they're on that slippery slope of getting suicidal. So let's say after the call, they feel better, but then they're starting to get agitated again, that they can develop a plan of, what coping strategies would work and what might distract them. So that certainly music, art, I think various things that the person who's asking the question was talking about can, you can develop a plan so that someone doesn't get to the point where, the parts of the brain that are responsible for sort of more logical, less heated thought, but they're not hijacked, that you can avoid. And, we all know what that feels like, to sort of you're in a state where you can think clearly, and it's called like a cool state, in contrast to being so overwhelmed and hot where you know you're not thinking. Right. So did that sort of address the question?
Yes,
That's fine.
Oh, good.
Using having a plan to cope. So the very things
Oh,
that
definitely.
the art, the music, and play could be that coping mechanism. I feel as though I'm slipping, I go and I paint. I listen to music. That's what I captured from your answer. So thank you very much, Professor. God bless you.
Sure.
we have another question here. I would just ask for a little bit more elaboration, Dr. Gould, on the training for these crisis counselors. Like, what does that look like? How long they're in training? Forgive us, we probably didn't hear that, but if you can elaborate more on.
Right. I didn't spend, that could be maybe next year's talk. we'll be on the training and we'll plan that, and hopefully maybe even in person. So it's changing, getting more standardized. You know, now that there's a lot more federal funding, there's also more responsibility. So, but I'll first talk about the past. I'll talk about the present and the future. So in the past, I mean, it did vary because these were independent crisis centers. In the National Suicide Prevention Lifeline has been trying to standardize it, but usually it, you know, could be about 75 hours worth of training in suicide risk and management skills, which included connection and so on. And the crisis centers, you know, develop their trainings on their own. So, you know, there may be some centers that had 40 hours of training, but that was just the first step, because then there's role plays, right? They're not going to just let someone get on and start working with a suicidal, you know, person or another person in crisis. And then there are some trainings that now, especially because they're being standardized, involve simulations that, you know, you can, there are these programs that you can, you know, sort of get tested on how you're interacting with, you know, these different scenarios. So they have simulations as well. The initial calls that the crisis counselors will take will all be supervised. So that someone literally will be, you know, sitting next to them, listening, you know, to what's going on, so that they can, the supervisor can shape that interaction as well. And there are now standardized, I mean, it just got launched on the Lifeline, but you have to be part of the Lifeline network. These online trainings, and then there are, you know, online tests as well with regard to engaging with the callers, risk assessments, and then the model has, you know, has different stages of having safety assessments, collaborative problem solving, trying to engage people with getting additional services. And so that these are online trainings that some have already been developed, some not. So that's really the present and the future, is to standardize the training across the network. But now it is variable, but they get a lot of training and practice in suicide risk assessment and management. So that's just the tip of the iceberg. So I think that would be for next year. And I see that Dr. Senior is here as well. So I don't want to cut into his time. So hopefully he has a lot of time to present his very interesting work as well. I'm excited about it.
Yeah. Thank you so much, Dr. Gould. That was very insightful, learned much. And yes, we do hope that next year we come back with more.
Talk about that. Yeah. Okay.
Training. That was great. Thank you again.
Thank you. Well, thanks.